Hello, my name is Liz Highleyman, editor of Cancer Health magazine, and we're here at the conference, the 25th conference on retroviruses and opportunistic infections in Boston, and today we'll be talking about liver cancer, which is a growing problem worldwide. I have here Dr. Massimo Colombo from Humanitas Hospital in Milan, and he's also chair of the EASL International Liver Foundation. So Massimo, first of all, let's tell us a little bit about the changing epidemic of liver cancer or hepatocellular carcinoma, both in the US and worldwide.
In 2015, there have been more than 100,000 new cases of liver cancer worldwide, and 95% of them could live only 1 year, no longer, because the vast majority of the diagnosis is done late and possibly because there is not enough screening program going forward around the world. There are substantial differences in the epidemiology of liver cancer across the countries. For instance, in America, hepatocellular carcinoma, which represents 90% of all primary liver cancers, is on the rise and represent the fastest growing cause of death due to cancer. Whereas in Europe, there is a stratified situation whereby Southern Europe is witnessing a decline in the incidence rate because there are countries who were able to curb alcoholic liver disease, prevent transmission of viral hepatitis through vaccination, and of course, screening of blood donation for hepatitis C help a lot to prevent transmission of progressive liver disease, which is not the case in Northern Europe, where there have been a lot of epidemics of viral hepatitis spread through parental risk behaviors, and as a consequence, hepatocellular carcinoma is on the rise in Northern Europe.
Okay, so when you say the vaccine, you mean for hepatitis B, because there isn't one yet for hepatitis C, so that's starting to have an effect at a population level. Is the ability to treat hepatitis C with these new effective treatments having an effect on liver cancer rates yet?
Yeah, first of all, vaccination against hepatitis B has changed the landscape of the primary liver cancer in China because they start quite early. And now there is a juvenile population associated liver cancer that is on decline substantially, not only in Taiwan but also in mainland China. For liver cancer related to hepatitis C, we have had few scarce data in the era of interferon therapy demonstrated that a sustained virological response was associated with a decline, but not completely elimination of the risk. New DAA have been associated with a fast decline in liver cancer. The huge population at Veterans Affairs Hospital, 129 hospitals that provided enough data to demonstrate that DAA are safe and reduce both mortality and the incidence of liver cancer in hepatitis C infected population.
Right, and that sounds like something we should expect to see continuing going forward. In terms of how to get more people screened and treated so that they don't ever develop liver cancer, what would you recommend along those lines?
Well, this is the real issue here in America, because there is enough data to say that the patient access to surveillance, meaning performing abdominal ultrasound every 6 months whenever the patient has chronic liver disease, is rather limited. And this is the consequence of a number of barriers that span from geographical issues to poor education and also lack of infrastructures. Having said that, screening definitely is associated with a decline in morbidity and mortality because it allows the recognition of an early cancer that is easy to treat. And there are also robust data telling us that there has been a clear-cut decline in the cirrhotic population that has been subjected to semi-annual screening with ultrasound. The very first data came from Japan and China. Europe came second, but also America is generating enough data. You asked me how to improve patient access to ultrasounds. First of all, you need to bring the ultrasound-based screening programs from the hospital inside within the community.
Okay.
And second, hopefully, we need to generate a point-of-care, user-friendly, non-invasive methodology to diagnose chronic liver disease and therefore identify the potential targets to be screened.
Okay, okay. And moving on to treatment, I understand there's some new types of treatment that are a little more promising than the previous ones, which generally weren't highly effective.
Right. You are alluding to immunotherapy. Well, immunotherapy covers an important area of hepatology, namely patients with advanced liver cancer, those who have a great burden of cancer that exceeds criteria for resection, transplantation, or radiofrequency. These patients, until yesterday, rely only on the use of the so-called targeted therapy, and more recently, a second-line therapy with these targeted molecules.
So what would be some of the examples of those
For instance,
targeted?
sorafenib was the master and commander, and for those patients who can tolerate sorafenib but fail to respond to sorafenib, now regorafenib is available as a second line. There are also two other molecules that have been registered quite recently. Lenvatinib, which is a targeted molecule first-line therapy, which has the disadvantage of not allowing the patients to access a second-line regorafenib. And there is another second-line targeted therapy, which is cabozantinib, which appears to be safe and effective. So having said that, there is a basket of targeted molecules that are available to treat patients with advanced liver disease, but the benefits in terms of life extension are rather limited, are poorly tolerated, and might be toxic. Conversely, immunotherapy, which is based on the principle that you might reactivate endogenous immunity against the liver cancer, breaking down immunotolerance phase that accompanies our life, proved to be very effective, providing some 26 months of survival to naive population and up to 16 months of survival to patients who fail to respond to sorafenib. So, although limited, it appears limited, but it's a huge advantage compared to the previous therapies, and they are safe and very well tolerated.
Okay, and which drugs are these?
Nivolumab has been the master and commander because it has been registered here by Food and Drug Administration.
I think it was just approved in the fall for
It has
liver
been
cancer.
approved a couple of months ago and is under scrutiny in Europe and elsewhere.
Okay.
Very promising. What is the real, I would say, bottleneck of immune therapy? Cost. It's costly, unfortunately.
Right, right. So going forward, are there any sort of future types of therapy that look like they might hold promise somewhere down the road?
To my understanding, immunotherapy will be promising as an adjuvant therapy in combination with those therapeutic methods that aims to remove completely small cancer, because they could really provide a prevention of recurrent cancer, which is not available currently.
So it sounds like a big part of the challenge is finding it early enough that it's more easily treatable.
Is the only hope to get a cure from liver cancer, early diagnosis based on screening of patients at risk.
Okay, well, thank you very much for chatting with us today, and signing off from CROI in Boston.